Great. Welcome everybody to this month's webinar. Hot topic this month. As you all know, testosterone has become a big thing, and we're going to talk about that. Um, uh, Before we get started, I would love to introduce or reintroduce, because we've spoken before in this series, Dr. Amy Vodich. So, Amy, why don't you give everybody a little bit about yourself, and then we'll launch in.
Sure. It's nice to see everybody. Again, thank you guys for joining us on a Thursday in December, the busiest month of the year for so many of us. So
Yep.
thanks for coming. Um, Becca and I just love talking about all things hormones. So when she asked if I would be happy to join the webinar, the answer is always a yes, anytime to chit chat. So I'm Dr. Amy Vodish. I am a OBGYN at Stanford. I specialize in complex family planning. So I'm board certified in complex family planning. And then I'm also a menopause expert and am certified with the Menopause Society. And Becca and I are co-hosting a podcast together all about perimenopause because I love menopause and I really love perimenopause because it's the perfect blend for me of complex family planning, contraception, and menopause. So it's like all my faves. And we're also writing a book together. So it's super fun. We clearly love working together. So we're super happy to be our own. I just saw somebody in the chat say we love overreactive. Yay! So glad it's been so fun. It's such a fun thing to do. I'm not a natural podcaster, but it's been great.
And Amy and I have known each other. So Jeanette sponsors these webinars. Amy and I have known each other through Jeanette for a long time. She's been a consultant for us and really helped us to sort of guide where we're going with our services. And we just love talking about hormones and teaching about hormones, and are so excited to share with you guys sort of what we know. Just as some background, we have written about this topic. So several years ago, there was a global consensus on the use of testosterone in women, and Amy and I, along with Dr. Ashley Fuller, pulled together for the Green Journal an article on that, sort of summarizing, because the global consensus is a little more international and talks about things that we don't necessarily have access to in the United States. So we reframed it for our practice. But a lot of what we're going to talk about today does come from that statement and come from sort of the basis of, well, what research do we have on this and what research do we not have on this? But I think the best place to start is, Amy, why are we talking about this? What's going on with the testosterone craze right now?
Oh, it's insane. So I've been focused on menopause for a long time and perimenopause for a long time, but I would say definitely within the last year and a lot in just the last few months, people are coming in and they want to talk about menopausal hormone therapy, which is great. But they always ask about, and what about testosterone? I'm going to need testosterone. I don't think anybody mentioned testosterone to me several years ago. And now it's like the thing that they want to talk about. So we can thank our influencers, our social media influencers for that as well.
Mm-hmm.
And it has been sort of touted as this like new fountain of youth and we all need it and everyone should have it. And if your doctor doesn't give it to you, you need to advocate for yourself and you have to demand it. And so that has become as much a part of my conversation as just talking about estrogen and progesterone, which before I felt like, oh, this is so great that I'm getting people in to talk about menopausal hormone therapy because for so long, everything in the lay media was it's negative and it's bad and it's terrible.
Mm-hmm.
And I'm so happy that people are coming in and wanting to hear about it. And now I'm like, oh, here's the testosterone wave. So
Yeah.
that has been, I think, for me, the biggest thing has been what's going on in social media.
Yeah, no, I definitely agree. In fact, I was thinking about this webinar on Wednesday. So I saw 7 patients yesterday, and 6 of them asked about testosterone.
Mm-hmm.
Yeah.
Yeah,
Um,
that's
and
about right.
even I'd say 6 months ago, we weren't seeing that, right?
No, I agree. It's really picked up. I don't
Hmm.
know if something happened over the summer and then the fall. I don't, yeah, definitely has picked up for sure.
Yeah. So we should probably start by centering on some physiology, right?
Yeah. So I think one of the questions that I get asked a lot is, or there's sort of this thought of
Hmm.
like that when we are going through menopause, not only are our estrogen levels tanking, but our testosterone levels tanking as
Right.
well. So what do you say to, folks when they come in and are like, well, I need the testosterone supplementation, it's totally taken a hit.
Yeah. This is a really good question because I think we are never, it doesn't matter what specialty you're in, OBGYN, primary care, urology, we are really not taught about testosterone physiology in women. It's sort
Yeah.
of the ignored hormone in women, right? We think
Yeah.
of women as estrogen and progesterone beings, but we are three hormone beings. We're estrogen, progesterone, and testosterone. But what we know about the physiology of testosterone is that testosterone is at its peak in men and women in our 20s. And then it comes slowly down over the course of our lifetimes. That's normal.
So that
It
explains a
does,
lot of our behavior in our 20s. And is that what you're saying?
yeah, probably. Slowly down over our lifetimes. It does not tank at menopause. In fact, it doesn't change at all at menopause, really. There's a small inflection because of sex hormone binding globulin changes, which we can discuss in great detail if we want to. But really, it continues down this very slow trajectory down and really doesn't tank until our 80s in either of the varieties of our species. And one thing that I end up explaining a lot, especially to perimenopausal women who are like, I have hair loss and acne and chin hairs and weight gain around my middle and I need testosterone. I'm like, that's only going to make those worse because those are signs that you're actually reading a bit more of your testosterone because as your estrogen's sort of starting to go up and down and plummeting and you're losing your sex hormone binding globulin, you've got more free testosterone out there.
Right. Yeah.
But
So
they
you
don't
actually
believe us, right?
become a
Sometimes
little
they've
bit,
already been to somebody who tested their testosterone. What's the problem there? It said
oh,
it was
yes.
zero
They
or
said it was zero or it's
undetectable.
low, it's undetectable.
Right.
Shockingly, it's undetectable because the assays that we have available sort of in our standard labs
Mm-hmm.
um, aren't really designed to detect the low levels that females have. They really were
Right.
designed for detecting male levels of
Mm-hmm.
testosterone. So shockingly, we're trying to use parameters for men, probably white men, is what this test was designed around, and then try
Mm-hmm.
to apply it to women. And we're just different. And so the testing that's available, like I said, they're unreliable and they're not standardized. So
Mm-mm.
one lab might say one thing, one lab might say another. And so that makes it really difficult because it's hard to sort of say, okay, well, you had it checked at lab A and then you had it checked
Mm-hmm.
at lab B, and I don't really know what to tell you. There are so that's what most of the assays are. And that you can
That's your free and total testosterone you can order at LabCorp request.
right, exactly. So that's your like general testing that you
Mm-hmm.
can get there. And then you can do like liquid chromatography or mass spectrometry testing, and that's a little more accurate for sort of those low levels, a little more accurate for women. Again, not internationally standardized, so that makes that a little bit more difficult. So you can use those, but I think that, that type of testing isn't readily available. And so I
Mm-hmm.
think when we think about the regular tests that we have access to, that our patients have access to, generally speaking, not super helpful to say what your particular testosterone level is. So we have
Right.
patients come in all the time. They're like, it's super low. And I'm like, is it? Or do we
Yeah.
just have a test that can't really figure out what it is, what's going on for you?
Right. And I have on occasion sent a liquid chromatography, but in general I found it's not covered by insurance. It's a really expensive test.
Right?
Um, I do use when I'm using testosterone, we'll get in later when we use it, how we use it.
Yeah.
When I am use it, I do start with a free and total and monitor with a free and total because what I do know is it is valid at male levels. So if somebody's showing me that they're under the female level or even zero, that's fine. They don't have too much. I'm
Yeah.
using it to make sure I'm not getting into the too much range. And I have to
Right.
explain that to patients. They're like, you just told me this is an unreliable test. Why are you sending it? And I say, because because I know it's reliable up here. I just want to make
Yeah.
sure you're not up here.
Right. And so when we think about like when do we test testosterone? Like when is it helpful to
Hmm.
do so? And I think about it right when you have your patients with like PCOS and things like that. Like certainly we want to be checking those levels and it's appropriate then. And then also for those patients, once they have come in and we've talked about, are they a candidate for testosterone therapy? Do we think it would be helpful for their particular complaints? You need a baseline because you want to make sure you're not starting too high already. And then when you're, monitoring therapy, then it's helpful because you're looking for a relative change. You're not necessarily going to get like absolute values for that particular person, just kind of given the limitations, unfortunately, of the testing.
Yeah. And I think that's really important to understand because I think, there's no reason it's not like the labs are telling us that this is not valid at female levels, right? They're just reporting back a number.
Yeah. No, exactly. And your lab might come back with ranges for them that they can see. And so that's what their lab has come up with. But what's just so difficult and challenging is it's not really consistent across labs. And so that makes it really hard. Yeah.
Yeah.
So, and I think, one of the difficult things that I see is that people will say, well, I was given testosterone at this, this other clinic or whatever. And, and my energy is so much better. I'm building muscle. I wasn't able to build muscle before. So what's the problem? Like, what's the problem? What's the harm? Why can't I keep doing this?
Right.
And I mean, I had a patient this week. It got very testy in there about this. And I'm like, listen, I'm just telling you, my opinion, but what do you say when those patients come in?
Yeah, it's actually a challenging conversation. I'm glad you brought that up. It's, testosterone makes you feel good for some period of time. So what I tell my patients is like any anabolic steroid, you're going to feel great when you first start it. And you're going to see muscle building, and it's just going to feel like this miracle drug. And then that dose of testosterone is not going to work so well, and you're going to need more. And generally, to get those energy and muscle building results, you need to take above the normal female range for testosterone. And, we do not have studies that tell us about the long-term effects of doing so. And, we know that testosterone changes the balance of our cholesterol parameters. So your LDL will go up, your HDL will go down. We do not know what landing a woman in the upper range of normal for a woman or even above the normal range for a woman does to her cardiovascular system long term. And invariably, if you're getting this effect and you're looking to maintain this effect, you're going higher and higher.
Yeah.
And you're going to get side effects.
Yeah.
And we know that side effects take a while to show up. So women will say, but I haven't gotten any of those side effects. And the side effects we talk about are chin hairs, male pattern baldness, deepening of the voice, turning of the clitoris into a small phallus. Always a fun one when you pick up testosterone use based on their phallus.
Yep,
Changes in body hair distribution. Changes in weight gain. They start to gain visceral weight. So you start to see these side effects probably 6, 9, 12 months into therapy.
Right.
And so it's not an immediate thing. And then once they've started down that pathway, does it reverse?
It does not.
It does
And
not.
that is so hard. Yeah, that's the hard part, right? Like,
and that's really where the big issue comes in because they're like, no, it's fine. I'll just stop and my voice will go back up. I'm like, no, it's never going back up. And we know this. So those of us who've worked in the transgender space know that once we use testosterone to help someone transition from female to male, even if they lose coverage for that testosterone, they go off it for some period of time, they don't lose their masculine features.
Right. Yeah.
And, this is well documented. So I think in my experience, when people have come in from these outside clinics where they've been given these T levels, they're not told any of this, are they?
No, I know. They're told they're going to feel better.
Right.
They're told you're going to have more energy. You're going to feel great. You're going to lose weight. You're going to gain muscle. And that's, that sounds awesome. And sign me up. Like if that's what somebody's telling me, right? Because we're exhausted. Like you're so tired and your body's getting flabby and your athletic performance is going down, especially for elite athletes. They notice this big change. Like people are desperate. Like I get it. Like I get why this happens. Like I don't, there's no judgment. I get it.
Yeah. And I think you brought up two important points. One is like elite athletes. So remember that the use of testosterone in elite athletes is actually banned.
Yes, it is.
So I have had to tell a triathlete that they are now officially doping and disqualified from competition. But more importantly, like I think I brought up this point and I want to emphasize it. We don't know. We have not studied this. We have not done the studies. I'm not saying it doesn't give you energy. It probably does. But women deserve better than untested or anecdotal medicine. They
Right.
deserve medicine that is based in evidence and fact. Because that's, when we've done these things before where we do something for women anecdotally and it seems to make them better and we just go with it, we've caused harm.
Yeah.
And, we could very seriously cause harm here.
Yeah.
But
Oh,
on the
yeah.
other hand of it, Amy, is we want our patients to feel better, right? We
Yes.
understand it and we want to make them better. How do you navigate sort of that balance?
Yeah, well, there's different things that you can do. So first I want
Mm,
to say it comes across maybe a little bit that like I'm anti-testosterone or I
yeah.
don't think people should be on it. And that's not the case at all. I
Hmm.
think there's a real role for it in certain circumstances, which we can address in a moment. But when folks are coming in and they're asking for it because they want more energy and they want to build muscle and they're using it for cosmetic reasons, like I want to keep my muscle tone so that I look better. Um, that's where I start to get worried and nervous because, like you said, in order to have those kinds of effects, we probably have to use doses that are unsafe or at this point haven't been tested and shown to be safe. And so we don't want women to be guinea pigs. We, like you said, we deserve better than that. So,
Hmm.
what we talk about is one, menopausal hormone therapy. That can be helpful in and of
Hmm.
itself. So, um, if we treat a lot of the other things that are going on, improve your sleep quality, get rid of your hot flashes, your night sweats, help you with your brain fog, treat your anxiety and your depression. I mean, menopausal hormone therapy can help with all of those things. And once your overall sense of wellness is better, you're feeling better. One, you're just going to feel better. You're going to be sleeping better. Your energy
Hmm.
levels are going to go up, and you're going to have more capacity to be able
Hmm.
to exercise, which we know gives us natural endorphins, and people feel better when they're able to exercise. So I talk a lot about that. And when I'm the other thing I talk about is your sort of when people are really focused on that muscle mass and the fact that we lose muscle mass during the menopause transition is I talk a lot about strength training. And
Hmm.
bodybuilders aren't just using testosterone. They're strength training. They're using testosterone to get to sort of, you know, unobtainable physiques, but which is not our goal. But we talk about, so I talk a lot about strength training and resistance training and how you sort of need to flip a little bit. Because a lot of my patients are like, I do cardio 7 days a week. I'm like, we need to change up that ratio of your cardio. I still want you to do cardio because it's so great for your cardiovascular system. It's great for your mental health, getting outdoors,
Hmm.
being in nature, amazing. But that strength training piece has to become an equal player in your exercise regimen and how
Yeah.
we're, training our bodies. So
But that doesn't sound easy, Amy.
it's not easy. It isn't easy. I mean,
It's
that's the
not a
hard
simple
part.
solution.
It is not a simple solution and it is much easier. And listen, I love my dad to the end of the earth, but that man would rather take a pill than do any of the other things that we need to do. And I get it. Like that's way easier than it is to kind of do these lifestyle things. But the menopausal hormone therapy could be a relatively simpler fix. But these lifestyle changes, and it's not just an investment in like managing you through the menopausal transition, but it's an investment in your long-term life, like your longevity, your, what are you going to look like or feel like, and how is your body going to be able to move in 10 or 15 years? And the difference, like layering in those good habits now will make then. And my sort of like philosophy on the menopause transition is all of our bad habits come to roost at this point. Like all the things that you could get away with before, the lack of sleep, the not really exercising, the poor nutrition choices. Listen, I do all of those things. I wish that I could like snap my fingers and suddenly do all the things that I tell my patients to do. But all of those things really come to a head during this time. You just can't get away with it like you used to. And it
Right.
sucks.
Yeah,
Not gonna
yeah.
lie. It's
It
not
sucks for
easy.
us, sucks for our patients.
But you will feel better doing these things, and this will treat you so much better in the long haul than taking super therapeutic doses of testosterone. Like that
Yeah.
is a short term fix with a lot of long term issues that could result from that. So
Hmm.
we have to think about what's going to be best for sort of where we want to be in 5, 10, 15, 20 years, right? We're young, we're 50, we're 48,
Right?
we're whatever. We want to live another 20, 30 years. Taking high
40.
dose or, 40, 50, whatever, we don't know. We don't know what our longevity is going to be, but
Yeah.
we want to do it in as healthy of a way as possible. So that's sort of the spiel I get. Not everyone's thrilled with my spiel, but that's sort of the spiel I give.
No. And fundamentally, our patients will find this somewhere else, if not with us. But at least they'll be
Right.
armed with the information and understand what they're doing maybe a little bit better.
Yeah, exactly. And that's the other thing that I tell folks is I'm like, listen, I'm going to give you the information that is within sort of the governing body, the standard of care. This is what we feel to be safe. And you may find that that works for you and helps you obtain your goals. You may find that you want to go outside the box and obtain care in another place. I'm just giving you the information that I have, and I'm telling you my um, sort of what we think are the risks and the benefits, the pros and the cons of these different approaches. But each patient has to make the decision for themselves, and they absolutely will find somebody who's willing to
Hmm.
put them on mass doses of testosterone. They
That's
will.
true.
Yeah. And then we see them back and
Yeah.
there's a problem. But we're always happy to take care of you, right? Like we'll
Right.
just take care of patients and whatever, however they come to us. And that's just what we do.
Yeah.
Yeah.
Absolutely.
So, okay. So now we've talked a lot about
Why
what
not to do it?
why not to do it, what we don't use it for. So when people come in and they want testosterone, what do you say or how do you counsel on the indications for it? Like when do
Right.
we use it? When is it something we should consider?
Yeah. So I go back to the data. As I mentioned before, I'm a big fan of data.
We are big fan.
And we do have data on the use of testosterone in women for hypoactive sexual desire disorder.
Hmm.
And I always like to step back when I'm explaining this to women because I just told them that it's not going down. So why would we need to replace it for this indication? And I tell them we're not replacing it. We are using testosterone because we know it has a side effect. And one of its side effects is that it can make you hornier. And so we're using it for that side effect. I'm not replacing something. I'm using a medication in a relatively safe way for a side effect that I know that it has.
Hmm.
And I think explaining, the loss of ovulation, the loss of spontaneous desire, and working through responsive desire and all those strategies are
Right.
really the important first step. But for my patients who have done that work and are still struggling to sort of build back the habit of sexual function, testosterone can be really helpful in
Hmm.
that. And the data tells us it is helpful. And the data comes from a large, well designed, randomized controlled trial where they used something we don't have available here in the US. They used a 300 microgram testosterone patch, which is dosed for women, and they had real and placebo, and the women on the real patch did increase their sexual function and their sexually satisfying events. They also then followed those women on continuous use for out to 4 years and showed no harm, which I think is really important for all of
Yeah.
us. But I'm going to reemphasize this was a 300 microgram patch, and they followed these women's testosterone levels and made sure they were not exceeding normal female levels while
Hmm.
using this. So they were using it within the physiologic parameters.
Right.
And, they actually submitted this data to the FDA, and the FDA said, well, I know you have 4 years of safety data, but we think there could be long-term harm, so we're not going to approve this. Which is probably the worst thing they ever did to all of us, because if we had a safe and effective female dosed thing for this indication, then we might actually be in a better place right now.
Right.
But we don't in the United States. It is available in Australia.
I know that's
So
basically the only place, right?
it's basically the only place. So how do we do it safely in the US? And I like to bring this up because, a lot of people don't even know where to start with this. Like if you have
Yeah.
someone who's the right candidate and you want to use it, what do you do? So you can use male dosed FDA regulated products, and that's either Testim or Androgel,
Hmm.
and you use them at 1/10 the dose. Testim is very easy to do that if you can get, so Testim comes in a box of 30 tubes or 30 ketchup packets, but you try to get the tubes. And each tube has 5 cc's in it.
Hmm.
And for a man, that's a 1 day dose. And for a woman, that's a 10-day dose. So what I do
Hmm.
is I hand my patients in my office a 5 cc syringe and I send them to the pharmacy for their box of Testim tubes and have them empty the first couple of them into a 5 cc syringe and dispense half a cc a day until they get used to what that looks like, and then they don't
Right.
have to use the syringe. But basically telling them this box should last you 300 days. That's also important because, of course, this is women's sexual function, so none of this is covered by
No, of
insurance.
course not. Of course not.
Um, good old Viagra covered by everybody. Nothing for women is covered. So
Nope.
what I do is have them go to the pharmacy with a full box because they can't split up the boxes. They have to dispense a box and have them buy that box using a good RX coupon. It's usually under $140 for basically a year's worth of therapy.
Yeah.
And I have them check their T levels at baseline
Hmm.
at 3 and 6 months, and then every 6 months that they continue on it. So I can make sure they're not getting too high.
Yeah.
And I have written instructions for how to use this, and we're very careful with it, but this can be done. And it's actually more affordable than most compounds
Yeah.
if you use the
Absolutely.
coupons.
Yep.
And I know what's in that packet or that bottle.
I know that's it. It makes me,
Hmm.
feel much more secure that using the FDA and regulated products, because like you said,
Right,
you know what they're getting. The
right.
reason why we want to have the tubes and not the packets is just because I think the tubes, um, the product tends to be a little bit more stable in there, so
Hmm.
you don't get any like
Right.
degradation of it. And so with men, it's the packet, they use one packet every day. With women, you kind of open the packet and it can kind of the shelf life of it,
Yeah.
I think, isn't quite the same. So if
Yeah,
you
and if they can only get the packets, I do have them continue to use the syringe because it's really hard to dispense out of a ketchup package and close it
Yeah,
back up.
they just make sure that this little packet lasts 10 days. You're gonna get
Yeah.
like half in one day and then like
Yeah, I
drip
know.
the other ones. It doesn't work. Yeah, the tubes are better, but if they can't, then you get
Hmm.
the packet and you put it in the syringe, and that actually works really well.
Hmm.
I like to tell them to use it on the back of their calf is one of the
That's a great
places I'll
place.
tell them to
I have
put,
them do
because
the thigh usually, but yeah.
so someplace where like if there is a little bit of localized hair growth stimulation, you can just shave it right
Yeah.
off. So that's kind of a good spot to do it. Yeah, it's been interesting. It's always interesting prescribing it. The pharmacists are always like, "What's happening?
Yeah.
What are we
I
doing?"
have
But we're
actually
getting
I have actually gone to, so pharmacists have caught on. So I actually prescribe it as a tube a day, but I give my patients very strict instructions because I've had pharmacists come back and say, I can't dispense 300 days of medication when I actually prescribe it correctly.
right. Okay, got it. Ooh, that's good to know if I get
Yeah.
pushed back on that. Okay,
Yeah.
right, right, right.
So there are other forms, right? There's compounded testosterone, there's pellet-based testosterone. Why are we not recommending those?
Well, the so let's start with the compounded. So
Mm-hmm.
it's not that I've never used compounded medication. I think we have for those patients who have allergies, and we
Mm-hmm.
just don't have anything on the market that's going to work, that isn't going to cause it, some sort of an allergic reaction, or they have an intolerance to a particular thing.
Mm-hmm.
So, and you can find, I think we have a reputable compounding pharmacy relatively near to us. So like if I have to compound something, we can. But in general, I'm not a big fan. And the reason is because when you compound medications, um, again, it's unregulated. So you never really know exactly what you're getting and what dosing. And they've done studies looking at different compounded formulations of medications, and, same prescription given to the same pharmacist, same pharmacies, and, different pharmacies across the nation, but same prescription. And they all came back with something totally different. So when you look at like the actual concentration. So I always get a little bit nervous, especially with something like testosterone, where you're kind of like, oof, am I actually giving them what I think I'm giving them? So
Mm-hmm.
that makes me nervous, because you certainly don't want to overdose somebody. Because again, that can lead to side effects that are not reversible. So one, I'm not like a huge fan of compounding just because of the inconsistency.
Right.
Pellets, I have an even bigger beef with.
Oh yeah.
Yeah,
As as do I.
yeah, big beef. Um, pretty, There could be like a M&A fight with me
Mm-hmm.
and the pellet companies, but which would be hilarious. But
Mm-hmm.
the what I don't love about pellets is, again, not FDA regulated, don't always
Compound.
know exactly what's in there, and they are, put underneath your skin, and you can never get them out. And
No.
theoretically, they're supposed to do like a little dose every day, but once they're in, they're in. And so if you get testosterone levels that are too high, like, forget it. You
Mm-hmm.
have to just wait it out. There is nothing that you can do.
Right.
And those are the patients when I see people come into me with problems with the deepening of the voice, the enlargement of the clitoris, um,
Mm-hmm.
endometrial cancers, etc. Those are it's the pellet patients almost exclusively that I have seen
Yeah.
those issues in. And when your patient is on the phone and someone keeps calling her sir, and then she calls you in a panic because her voice is so deep, and you've like, well, this is the fifth conversation I've had where I've told you that your levels are too high. You shouldn't
Mm-hmm.
be getting the pellets, but they keep going back and getting more pellets and more
Yeah.
pellets because, as you said, you get to a certain level, you feel good for a little while, and then you don't feel as good anymore. So they give you more so that you feel
Mm-hmm.
better. And then the levels just snowball on top of each other. And that's where you see the like crazy high levels and the irreversible side effects.
And I've talked to providers who believe that they can do it safely. But realistically, these are compounded product made by somebody
Yeah.
you don't know. You don't know how much you're putting in, even if you think you do.
Right. And
And
you
you
may
also
be
don't know how it's going to absorb in that patient from their subcutaneous fat, depending on how deep it goes.
Yep.
There's It's just an unregulated thing that you can't even stop. At least with an unregulated topical compound, you can say, stop, that's too much.
Right, exactly. I mean, I would rather, if we're going with a
Uh-huh.
non-FDA product, which again, because we have Testim and we have
Hmm.
Androgel and they're cheaper, like that's cheaper to
Right.
go that route than it is to do the compounded route. But I'd
Hmm.
rather you do a compounded than to do a pellet. Like if I have to put them in order, I'm not saying I love
Yeah.
it, but like the pellets are just, that's where you get into
I
trouble.
also have an ethical qualm with the
Yeah.
pellets
Yeah. I
because
mean,
the
yeah.
way they're promoted is as a cash business that will make your practice very profitable.
Right.
And I think that introduces an aspect of ethical dilemma for the
Yeah.
provider.
Hmm.
You know, when I'm prescribing to a pharmacy, I'm going to use the best drug that I can think of to use because I'm not going to make any money from it.
Right.
But can that person in a clinic say, hey, I'm going to recommend we use testosterone, and here's a way you can get it from the pharmacy, or I can put this pellet in you, but the pharmacy one's just fine. Is that going
Right.
to happen? That's my question. And I'm sure there are people who are strong enough to do that. But I think there is an ethical question. I'll be honest.
Yeah, I think it's a slippery slope, and I think that
Yeah.
that's hard. It's getting harder and harder, as we know.
Hmm.
Insurance reimbursements are terrible. It's harder and harder to keep the lights on. I
Oh,
mean, a
totally
lot of
get it.
people use in
Yeah.
private practice, right? I get it, right? You're like, okay, how can I bring in some cash revenue into my clinic?
Hmm.
Totally get it. But I think this is one of those things where when it goes wrong, it goes
Hmm.
wrong, and there's nothing you can do to course correct it.
Right. Yeah.
Yeah,
No, I truly agree. And we've both seen bad outcomes. We've both seen endometrial cancer,
yeah,
right? From these, because remember, some portion of your testosterone, if it goes above the physiologic range, is going to convert into estrogen. And often from these outside clinics, they're not being given progesterone, or they're being given
or
topical progesterone, which is a whole nother conversation because that doesn't
right.
work.
It doesn't work. Nope.
Um, we heard a great talk at the North American Menopause Society on vocal changes.
Oh, it was fascinating. They
Yeah,
had a vocal specialist, a physician who specializes in the voice, talk all about kind of what happens to your voice in menopause anyway, and then what she sees in patients who are using testosterone, and sort of the deepening and the lowering of the voice that happens, and how devastated people are that you can't
right.
undo that. And so, um, you know, you know, are you going to die because your voice is lower?
No,
No, but is it something you wanna deal with for the rest of your life every time call on the phone, or just know that your voice doesn't sound like your voice anymore? Like,
right.
that's difficult, but it was really a fascinating lecture on, um,
Hmm.
how basically how your vocal cords are kind of like the vulva and the vagina and like the mucous membranes and the changes there and the estrogen and the testosterone receptors. I mean, my mind was blown. It was
Yeah.
fab.
And then, there was a case report just got released in Fertility and Sterility this week
Yes.
about a woman who on pellets had a testosterone level in the almost 1200 range. Now, everybody be aware that the upper limit of normal for a woman is 50, and
I mean,
that's well
that's
above the
heightened
upper
from,
limit for men who had a psychotic break and continued to do so until they got their testosterone levels down, then went back for another pellet and went through it all over again. It's fascinating read. So there's those types of side effects.
wow.
But more
I love the
importantly,
going back for another pellet after having a psychotic break because she didn't feel good because her testosterone,
she,
because she was on
right,
like,
you
it's like,
feel awful when you're coming off this stuff.
it's like being on heroin.
Yeah. And then, you know, years ago, the FDA put out a warning letter because BioTE, one of the main companies, had collected over 4,200 adverse events, but decided not to report them to the FDA because they felt that they were just distributing, they weren't actually generating the pellets, therefore it was not their responsibility. So there was a letter about that. And even in the studies that have compared pellets to traditional menopausal hormone therapy, they show significantly more complications from these. The data tells us we have more complications from these. There's one that came out a few years ago that showed about a 400 times complication rate when you use pellets as opposed
Yeah.
to FDA regulated MHT.
Right. Totally. Yeah. I absolutely believe that for
Yeah.
sure. I
Well,
mean,
we both know that you and I can talk about this forever,
true that.
but I'm guessing that people will have questions. And so I
Yes.
do want to leave enough time for Q&A.
I do love a good
Because you
Q&A.
guys do not need to listen to us drone on for an hour.
Right. No,
So we do have one question in the chat already, which is just to clarify, you are not prescribing endometrial protection for female physiologic T replacement for sexual dysfunction.
that is correct. Yes. So when you're doing physiologic dosing,
Mhm.
so when you're doing the physiologic dosing of testosterone and it's just so if I'm not dealing with estrogen and progestogen and we're just doing
Mhm.
testosterone, as long as you keep it in that physiologic range, then you don't need to counterbalance with the progestogen. That is correct.
I will qualify that with if someone's coming to me for sexual dysfunction, the first thing I'm going to offer them is menopausal hormone therapy because that's probably going to be one of the most effective interventions you can make.
Yeah.
It has a
That's my
beneficial
usually.
effect on
Yeah.
all aspects of their life so that they can get back into the habit of sex. It has beneficial effect on their vulva and vagina, on their arousal and responsiveness. So start there. So they're probably already on protection by the time I'm getting to testosterone,
Right.
but in the
Yeah.
rare occasion where I'm not, yes.
Yeah.
Another question, can you share what levels you're testing again for monitoring testosterone? I've been told everything from just total T to free testosterone to needing to calculate bioavailable testosterone.
Right.
So I'm typically sending a free and total, and it should on those levels have normal female range noted. I'm just really making sure we're not getting into the male ranges,
Yeah.
or staying under that normal female range, for either, but really I'm thinking more about the free because
Yeah.
that's what they're reading. How about you, Amy?
Yeah, no, the same. I sort of will do both. It's interesting because the ISWITch guidelines, I was just
Mm-hmm.
refreshing those the other day, and they talk about they kind of talk more about a total, and they look
Mm-hmm.
at more of like the total picture. And there is sort of this whole thought of like testing total free, getting a sex hormone binding globulin, calculating these things out. But again, that one that gets
I don't have
complicated.
time for that shit.
No, that's complicated. I don't do math. And then second, public math is not my strength. And then
Yeah.
second is again, things aren't standardized, so it makes it a little bit tough to be like, oh, you calculate this out and then you get this. Well, based on what lab value? So
Right.
I do both. So I do free and total, and I like to just kind of see like how everything is going. What's the trend? Are we still within normal parameters?
Yeah.
Yeah.
Um, and then age range for the women in the randomized controlled trial for sexual function. They were postmenopausal.
I was going to say everybody was postmenopausal. So we don't really have data on premenopausal and
Right.
perimenopausal, like the use of this in hypoactive sexual desire disorder in in premenopausal patients. Like,
Right. And
yeah,
remember, when you're using it premenopausal or perimenopausal, you have to think about contraception because the use of testosterone can impact a fetus who might
Mhm.
be female genetically,
Right.
but come out with excess testosterone features. So there's definitely more to think about if you're premenopausal. When we wrote our review article, a lot of the experts in the field and based on the data that we have recommended that it may also be beneficial in perimenopause, but we don't have extensive data there.
So if someone
Um,
wants to do a research study,
yeah.
that would be awesome. So we actually have data. Yay,
Yeah, that would be
research.
awesome. For lack of clitoral sensitivity and having hard time with orgasm, do you find non-vaginal tea to be effective? Or do you use a compounded vaginal cream? So I
Mm,
tend to start first of all with vaginal estrogen, external
mhm.
estrase on the clitoris.
Right. Yep.
Start there.
Yeah, exactly.
Um,
Not your suppository, not your Imvexy, not your whatever. You want it
yeah,
actually look externally. Yeah.
you need estrase on the clitoris. And so that's step one. There are studies out there looking at other compounds to that area of the body, specifically for arousal disorder. So I know there are people studying things like estetrol, there are people studying things like sildenafil. We don't
Yeah.
have that data yet.
Yeah.
Um, we have no direct data for T on the clitoris. Are the vulvar and vaginal tissues sensitive to testosterone? 100%.
Oh yeah, lots of
Tons of
receptors.
testosterone receptors down there.
Hmm.
So if you're going to do that, you need to be extremely careful because, again, you can create a phallus if you're using too much. I know a lot of people, there was a big trade in Scream Cream years ago. I
Right.
used to
Oh
tell my
yeah.
patients, I don't think the Scream Cream is working because of the testosterone or the sildenafil. I think it's working because the instructions say to rub on your clitoris for 10 minutes at a time. And pretty much anything you rub on your clitoris for 10 minutes at a time is going to help with arousal.
Is going to help with arousal. Yep. Yep.
But I think if you're being extremely cautious and following levels, you can probably try it. You're going to absorb T systemically from the vulva. So, just be aware you are giving
Yeah.
probably a systemic dose.
Right. Yeah. Depending on how often they're using it, how much,
Hmm.
and it's a little hard to know sometimes because the vaginal and vulvar tissue actually is a great sponge. And so sometimes if you really
Loves its
absorb,
hormone.
yeah, loves hormones. It's like super happy.
No, and I know there's a little bit of data that's very old out there about using T plus E compounds on the vulva in lichen sclerosis. And I think that, definitely I've tried that in a patient who had very refractory disease. So I'm not saying we never do this, but you just have to always keep in mind the cautions with
Yeah.
using these products and how are you going to monitor this person through
Right.
that.
Hmm.
But I think I always would start with estrase on the vulva before even moving on to something with a compound T in it.
Yeah.
And one thing we didn't get a chance to address today, Amy, and we're not going to go into in this webinar because it's way more complicated, is the use of testosterone after breast cancer. So I'm starting to see this come in people who are reading some very small case series that say it's fine to do testosterone with an aromatase inhibitor and you're not going to convert it to estrogen. I tell my patients, I just don't think we have the data for that. And I don't want to be doing something that could increase their risk of cancer.
Right.
So, these are people putting in a pellet that contains testosterone and aromatase inhibitor. Like the case series are 60 patients. Like we cannot make clinical decisions based on those. They're not really long term.
Yeah.
And the other thing to keep in mind is that breast tissue has testosterone receptors. We do not test testosterone receptor status in breast cancers. So even if it doesn't convert to estrogen, we don't 100% know that's not driving cancer
Right.
cells.
Right.
So I would never recommend that. But I do know that there are people out there who do, both for sexual function, but actually also for the control of menopausal symptoms when in women who can't take menopausal hormone therapy. But it makes me sort of question if you're actually managing hot flashes, is that through a conversion to estrogen?
Right. Yeah, exactly. Right. Because if we look at the pathophysiology of hot
Mhm.
flashes and the warm sensing neurons, at
Right,
this moment, we don't have a testosterone component to that. Doesn't
right.
mean it's not necessarily there, but
No,
that would make
I'll be
me
the first one to say we definitely don't know everything about women's physiology because we're playing catch up there.
nope. A little work to do, just a wee bit.
Yeah, yeah. Any more questions before we sign off on this one? And yes, we will send out our written testim instructions and how to use it and what I give to patients with our follow-up email. So anyone who registered will get that. I think it's based on the ISWITch recommendations and things we've learned at Menopause Society. So these are pretty well vetted in the
Yeah.
space of working in women's sexual function.
Right. So there's a lot of expert opinion on this, which I think a lot of thought
Mhm.
has gone into it for sure. And the one thing I sort of want to end with is there
Mhm.
is a place for testosterone therapy, as I said, it can be,
Mhm.
but this is an adjunct. This
Right.
is not a Viagra for women situation. We don't have Viagra for women. So, this is not our magic bullet. You're not going to take this. So libido in women, we could do a whole webinar just on libido in
We
women.
have
And
actually.
you've done it. So, and you've
Go to the
talked about
YouTube, it's there.
it's there. Sorry, I'm behind. So,
It's okay.
it's okay to use it. It's definitely okay to prescribe it, but other issues have to be addressed at the same time. And you are not going to fix somebody's libido with just testosterone if they don't do the work on internally what's happening with themselves. Like
Right.
it's not going to happen.
I mean, you can if you give them enough. If you make them into a 14-year-old boy with levels in the several hundreds, they will get
Right.
horny, but they will have a lot of other side effects.
Right, exactly. Yes, I'm saying safely. We
Yes.
cannot,
Yeah,
we will not be able to get there.
I
So you
figured
have
that's
to
what
do
you
the
meant,
work.
but I wanted to clarify.
Yeah, exactly. Exactly. So,
All right. Well, it's been fun spending this time with everybody. Thank you so much for coming, and we'll get the email out early next week with the follow-up from this, including those testim instructions. I wanted to also mention, I mentioned the patch, the Androfem patch, which is what was studied and submitted to the FDA and then not approved in the US, but is approved in Australia. Androfem, the company that makes it, does do a registration of prescribers from the US, so patients can send their prescriptions to Australia. It is a really onerous process, but if somebody's doing a lot of this, it might be worthwhile exploring. And
yeah,
maybe
yeah.
marginally legal. The whole sending of our prescriptions out to Canada or Australia is maybe not entirely legal, but the FDA
Yeah.
has kind of put us in a bind.
Yeah. Well, and that's what happens, we'll fill the space in any way that we can,
Hmm.
safely and unsafely, right? So,
Right. Yeah,
all right.
we know that from years
Yes.
of hormones and unsafe versions. Britt has just put in the chat next month's webinar. So please sign up now so you get reminders and the link for it. It is on metabolic syndrome and menopause. And it's going to be a conversation with Dr. Yashika Dooley, who's one of our medical directors, and Dr. Mary Beth Lewis Boardman, who is ABOM certified OBGYN. So a really great discussion because with on a topic that we know comes up all the time.
For sure. Oh yeah, that's going to be a hot one.
Yeah. All
That's
right.
a
Thank you,
great one.
everybody. It's been wonderful talking to you today, and best take care.
Okay. Thank you.